Okay. Um, Hello, everybody. I just wanted to hop on here and I'm going to give you guys just a very brief overview of the things we were going to address today in the lecture. So I'm sorry I had to miss. I know this is a big lecture to have to miss. I have a couple of thoughts on how we can make sure we cover all the content we need and there's not any gaps. But the first thing I want to do is, if you're looking at Unit E, you'll note that these are the chapters that this information comes out of, okay? I've done a pretty good job in the PowerPoint of condensing it down to what you really need. And then these are the objectives, okay? So you'll note from the objectives, there's several disease processes. So as I talked about in the fluid and electrolyte lecture, for disease processes, what I expect you guys to do is learn these pieces of that disease process. So find a way to categorize that, break it down onto a sheet, whatever you have to do to make sure that you understand those pieces of that disease process. And then these are our pharmacology pieces for this lecture as well, okay? So find whatever method works for you, but that's my best recommendation, is to make sure that you understand all of the components of those things. So let's go ahead. Oh, ignore my sourdough recipes. I'm sorry. Okay, let's go ahead and get started on our PowerPoint. So what I'm going to do is I'm just going to kind of hit the main points. So it's going to be up to you to really study this PowerPoint and filter through it. We're not going to talk just super duper in depth on every single slide, but I am going to highlight the things I for sure wanted to talk about in lecture. So objective 1, we're talking anatomy and physiology, okay? So these first couple slides are dedicated to the review of A&P of the heart. By this point, I expect you guys to know this. We've been through it in semester 1. You guys have all been through anatomy and physiology. I expect you to know, for the most part, the structures of the heart and the flow of the blood flow through the heart. So if you do not remember the blood flow through the heart, you need to refresh yourself on that. There's several really good videos on YouTube. I will post some on your supplemental info, but please be sure you understand how blood flows through the heart, because it's going to be very important when we start talking about certain disease processes and what that means, okay? All right, so we've got our anatomy, we've got our blood flow. Make sure you understand those components. There's a few more slides in here about the anatomy of the heart and what each piece does. So we know the heart is a muscle. We know that the heart has its own arterial system and vascular system, all right? So there's several components to that we're going to talk about. There's some physiology pieces to the heart, which are important to understand when we're going to start talking about those disease processes. So make sure you review those components before we get into the disease processes themselves. So objective 2, a focused physical assessment for patients with cardiovascular disease. So how do we assess the cardiovascular system, right? What are we actually looking for, right? So our cardiovascular system is responsible for carrying blood throughout our body, and that blood carries oxygen, right? So lots of times what we're seeing or what we're assessing for on these patients is lots of things related to oxygen carrying capacity. So when we talk about patients who have cardiovascular conditions, if they can't pump blood through the heart, then they're likely not carrying oxygen to places in the body, right? So these people may look really short of breath. They may appear like they're struggling to breathe. It may not be a respiratory issue that they're struggling with, but a cardiovascular issue. So we have to understand how we can determine the difference of that, right? So part of our assessment is our history, right? We always need to know what their history's like, what meds they take. Those are very important pieces of cardiovascular assessment, okay? And then on a physical exam, some of the key giveaways for cardiovascular issues are going to be vital signs and appearance, okay? So if they're having a cardiovascular problem, again, if we're hooking them up to vitals, lots of times, depending on the cardiovascular problem, they may have low or high blood pressure. Their heart rate may be high or low, okay? Respiratory rate, most typically, is high, okay? Because they're trying to breathe in more oxygen in order to allow their body to have more oxygen to carry out to their tissue and their blood, okay? Most of the time in cardiovascular issues, you're looking at people, they're short of breath, they're trying really hard to breathe faster to get more oxygen, okay? Temperature kind of just depends on the disease process. Typically speaking, though, general appearance of people with cardiovascular issues, depending on the disease, lots of times you're going to see people who are really diaphoretic. They're pale, right? They just look not great. They're dusky, and like they come in and you're like, ooh, like they just don't look good. Like you're concerned, okay? That's typically when we have a cardiovascular issue with a person, that's generally what they look like. And then head and neck, all right? So if we're going down the body and we're doing our head to toe, these people oftentimes, again, cyanosis, pallor, so that really dusky paleness to them. We're going to try and check that jugular venous pressure, and we're going to assess for any kind of fluid overload, right? So if we're in fluid overload, what that directly affects is the workload on the heart, okay? If we're looking at the chest, we're looking for anything that's directly related to the impact on the chest, right? So if it's, trauma related, that might impact our cardiovascular system. It's not really what we're talking about today, but in general, know that could make an impact on our assessment, right? One of the things we're always going to want to do is auscultate heart sounds, though, okay? We want to know, what does that sound like? Do we hear anything adventitious? Okay, do we not hear that normal lub-dub? Do we hear a gallop or a murmur, okay? And then our peripheral vascular system. Super important for the cardiovascular assessment, right? We're checking for those peripheral pulses. We're checking all of our extremities to make sure that blood is flowing throughout the body. If we're noting weak peripheral pulses, poor capillary refill, that's usually a sign that we're not getting good perfusion because our cardiovascular system is compromised, okay? Okay, so let's talk about objective 3, labs and diagnostics, right? There's a lot of different labs and diagnostics that are associated with the cardiovascular system. Some of the main ones you're going to see are on this slide right here, troponin and creatinine kinase, or a CK&B, okay? Troponin is really specific, so if someone comes in and they're concerned about them having a myocardial infarct that causes damage to the heart muscle itself, their troponin is likely to be elevated. So I do expect you guys to know what a troponin is. Have a reference of what a normal number is for a troponin. I didn't put it actually in here right now. But make sure that you understand what a normal reference is for a troponin, as well as a CK, okay? So a CK, or creatinine kinase, is an enzyme found in tissues, including the heart. And it's important to know that because if the heart muscle becomes damaged, that can elevate, okay? We don't measure myoglobin quite as often, but I did go ahead and throw it in there. Other things that are specific to the heart include lipids. So one of the things that directly impacts our cardiovascular function is how much plaque is in our arteries. So if our cholesterol is high, that means there's too much fat floating around in our bloodstream, okay? That fat has the ability to deposit inside the vessel. So if that fat's depositing inside the vessel, it's narrowing how much blood can actually flow in through the vessel, all right? So lipids is a very important test, because if the lipid levels are high, right, so if our total cholesterol or our LDL or our triglycerides are really high, that typically means that we are carrying too much fat inside of our bloodstream. We want to bring those numbers down to a healthy level. The HDL is actually good cholesterol and helps remove bad cholesterol. So we want HDL to be in the higher range. The rest of these we want lowered, right? So have, again, a reference of what those should be. Other things you're going to see, BNP is a very common one that they will likely see. So this is one of the primary ways that they will determine, like, if a patient comes in and they present with shortness of breath, and you auscultate lungs and you hear crackles, and they just feel like they sound like they're really full of fluid. A lot of times what they'll do to determine whether it's cardiovascular in nature or if it's respiratory in nature is a BNP, okay? So that BNP tells us basically if that patient is in fluid overload. So B-natriuretic peptide is released by the heart in response to fluid overload. So if our system becomes overloaded, our heart releases that enzyme, releases that hormone, and it shows up in our blood, okay? So that will differentiate between if it's respiratory in nature or cardiovascular in nature. A CRP is an inflammatory marker that they'll often do to determine if a patient's at risk for heart disease. Other things you might see, a complete blood count, every now and again. Other electrolytes, like we talked about in our last lecture, different electrolytes have the potential to affect cardiac function. So we always need to know if that's the cause for a cardiac problem, right? Is there potassium too high? Is there sodium too high? Like, is there other magnesium, calcium? All of those things are very important to cardiac function, right? And then kidney function tests, right? We always want to make sure we're monitoring those things. So labs and diagnostics continued. EKGs, you guys are going to learn a lot more about EKGs in third semester, but EKGs in particular are very important because they can tell us if a patient has an electrical issue, if they have an arrhythmia, if they're having a heart rhythm issue, or some ischemia, the heart muscle is actually impaired itself. So we need to make sure those are very important and very first line diagnostics for patients. Echocardiograms are an ultrasound of the heart that shows us blood flow through the heart and how well the heart is actually functioning. A lot of times this will tell us the total overall function of the heart too. So echoes are very important and a very important diagnostic piece in cardiovascular nursing. Stress tests can tell us, if that patient is basically like if you're getting on a treadmill and they're working you up on a stress test, it's showing how well your heart can compensate to increase stress on the heart, right? So what we should see if we're running upstairs, right, is that our heart can compensate for that. It can beat faster and provide our body with oxygen and we don't get short of breath. And a stress test on a patient who is experiencing cardiovascular compromise, most of the time their heart can't withstand that stress, right? So it tells them if something is going on that they can't tolerate. And then usually, if any of these previous tests are abnormal, a lot of times what they'll do is go onto a cardiac cath. Okay, so in this semester, a lot of your, I think a lot of you actually have the potential to go to the cardiac cath lab, but the cath lab is a place where they go in with a catheter through the radial artery in the hand. They go in and they actually access that vessel, they guide it into the heart itself, and then they insert contrast dye, and they can visualize the arteries and all the functions of the heart and see if there's any major blockages there, which is really, really important. It often can prevent major heart attacks from occurring if they can catch it in time. It's a super important piece, right? And this is usually how they diagnose if a patient needs like a quadruple bypass or a triple bypass or something like that, okay, or a heart stent, right? Okay. Other diagnostics that you might see, these are not quite, these are a little more first line. So basically what they call a CCTA is like a CT scan that provides images of the coronary arteries. They might do a cardiac MRI. Chest x-rays can tell us if the heart's enlarged, if there's fluid in the lungs. If they're concerned about something long-term going on, a patient may wear what they call a Holter monitor. And it'll record the heart rate. Like they send you home with it, you wear it, it'll record your heart rate, right? And then an event recorder. So like if a patient has frequent arrhythmias or they're experiencing like heart palpitations, they'll wear this device and it'll tell them like basically it when a symptom occurs, like it'll record that event. Okay. So let's go on to objective 4. So this is a big part of this lecture. Super, super heavy, super important though, okay? We're briefly going to talk through each one of these. I have the information you need to know on each slide. It's really just a matter of you guys studying that information. There are a couple that I'm really going to talk about a little more heavily than others though, okay? So again, what I expect you to know with each one of these disease processes is pathophys, etiology, what are the priority nursing interventions, the labs and diagnostics associated with each one, pharmacological treatment, and collaborative management, okay? Let me open this. I'm going to let you guys watch this on your own, but I do want to pull it up because I believe... We'll just skip that. I think it was actually... I gotta remember what it is.
So what do we mean when we say compensation? Well, let's remember that heart failure, you have this decreased ability to meet your body's demand.
Okay, so this video talks about the difference between compensation and decompensation when it comes to heart failure, all right? This is a video I was actually going to play in class, It's very important. This video explains this very thoroughly, and it's a great video. It talks about left-sided and right-sided, or there's actually a separate video that talks about left and right-sided heart failure. This one explains what we call compensation and decompensation, okay? So let's get back to our slide, and we'll talk a little bit about heart failure itself. So heart failure is the heart's inability to pump sufficient blood to meet the body's demand. It cannot beat fast enough, or it cannot carry enough blood, or it cannot compensate, basically, if we're stressed, to carry out the function that it needs to, okay? Things that typically cause this are, like we talked about, those coronary artery diseases, where we have that plaque buildup in the arteries from high cholesterol or a high amount of lipids that live in the bloodstream, all right? So those vessels have become occluded with fat, plaque. It's hard for blood to flow through them. We don't get as much blood flow through those vessels if we need. So inside the heart itself, where those arteries live, we can actually have fat depositing in that itself. So if we think about, not only is it depositing in the vessels in the peripheral bloodstream, so all over the body, but it's also depositing fat in the vessels of the heart, right? So if we're trying to pump the blood through that and we're continuously clogging it up, right, it's just going to continue to be harder and harder for that blood to actually pump through that system, okay? Other things, hypertension. So we know that high blood pressure exerts more pressure on the artery itself, so it's harder for blood to flow through it, okay? Valvular heart disease, which we'll talk about in a bit, and then cardiomyopathy, all right? So the heart muscle, if we're talking about cardiomyopathy, that basically just means that there is some disease within the heart muscle, all right? Okay, so there are there's different types of heart failure, all right? There's left-sided, right-sided, and high output. What I want you guys to know are left-sided and right-sided. High output is fine. We can have a definition. We don't need to study it as in depth. Okay, but left-sided heart failure. Okay, left-sided heart failure impairs the left ventricle pumping, which leads to pulmonary congestion. So I'm going to actually roll through my slides here, and I think it'll help us understand these pieces a little bit. So if we're talking about left-sided heart failure, what's happening? So the structure's on the left side of the heart, right? So if we're talking about blood, let's revise our blood flow through the heart. This is why it's super important to know, okay? So we have our blood coming in from the inferior and superior vena cava through the right atrium, okay, into the right ventricle, up through the pulmonary artery into the lungs, okay? So we're going to the lungs next. Our gas exchange occurs. It comes back through the pulmonary vein into the left atrium, down into the left ventricle and out through the aorta to the body. Okay, so we know that process occurs. If the left side of our heart is failing, which means that left atria and that left ventricle is failing, okay, that means that basically blood is it's going to go backwards, all right? So it's going to go immediately to the structure that is before it. So if our left atrium and our left ventricle is failing, what we're going to see is that blood is going backwards. So it's going backwards into that left. So if it's the left ventricle fails, it's going up into the left atria, and then as it continues to progressively get worse, it's going to go back through that pulmonary vein into the lungs, all right? So it's going into the lungs. Whereas sometimes left-sided heart failure will cause right-sided heart failure because it continues to backflow, right? So if it's going into the lungs, and we're continuing backflow into that pulmonary artery into the right side. But we'll talk about left-sided, so we'll stop there. So our left ventricle has failed, our blood flow has, we can't pump very well, so blood is flowing backwards or static, right? We can't get blood pumped out. So what you're going to see is that blood's backed up into the lungs. So we're seeing, like, these patients usually have very wet lung sounds, coughs, crackles, wheezes. It's super hard for them to breathe because their lung tissues and where their gas exchange occurs is filled up with fluid, right? It's filled up basically with the blood flow from the heart, okay? Lots of times you'll see blood-tinged sputum. These patients are super short of breath if it's really severe, right? They can maybe make it 5, 10, 20 feet, and then they're like, I gotta stop and take a breath, okay? So if you think about these people, lots of times when we're hooking them up, maybe they're really devoid of oxygen, but that's because those spaces where that blood or that gas exchange occurs are filled up with fluid. Okay, so that's left-sided failure. If we progress on to right-sided, so right-sided failure, we'll say right-sided failure on its own. Okay, so the right side of our heart is failing. So what that looks like, right, is our right atrium. So that blood comes in from the inferior superior vena cava into that right atrium, into that right ventricle, right? If those two structures don't work, that right atrium and that right ventricle, right, so it's got to go backwards. So before it ever reaches the right side of the heart, it's into the peripheral of the body, right? So it's into that inferior superior vena cava, and before that, it's into our system, right? It's into all of those veins and that vasculature. So it's into the vascular system, right? So what we see in these people is basically that fluid is backing up into the body, all right? So these people usually have really distended neck veins, lots of edema. A lot of times what we'll see is what you call ascites, or that fluid around these organs, right? And that's because, like, if that blood's backing up, it's putting, like, what we call, I think it's called, portal tension onto the liver space. So there's actually fluid around the liver. You're seeing lots and lots of edema on these patients. Fatigue. They typically don't have as much trouble breathing, but they do have trouble, you know, maintaining, like, just their body weight. It's really important. These are your types of patients that typically end up on fluid restrictions and things like that. So there is a bit of a difference, and I want you guys to understand that. Hopefully these visuals help a little bit. Once you guys have a generalized understanding of those two concepts, I do want you to go back over here and watch this video about compensation and decompensation. If our heart is failing as a pump, our body oftentimes will do what's necessary to compensate for it, right? So in both cases, in both instances, what our body tries to do in order to help itself is pump faster, right? Pump harder, pump faster. So if we can't get as much blood through, or we can't get as much blood out, the heart's going to try and fix itself. So it's going to pump faster. It's going to, a lot of times, there's a lot of different mechanisms that it actually talks about in here. And I want you guys to watch this video because I think it'll help you understand a lot of the pieces of just the pathophysiology of it. But it's a really good video. Talks about as you go on over time and your body's trying to compensate, right? What's happening is if we're living with heart failure for an extended period of time and our heart's just pumping and pumping and it's trying to pump harder, the heart's a muscle. The harder it pumps, the more it beats, the bigger that muscle is going to become, okay? So a lot of times what heart failure will result in is what we call muscular hypertrophy, or basically that heart becomes so enlarged and so big, but it's not necessarily pumping any more blood, okay? So it can cause a lot of other problems if we continue to go on and our body compensates for that heart failure. At some point, what's going to happen is it's going to decompensate, okay? At some point, our body's going to say, I can't do anymore, I can't compensate anymore, and we're going to decompensate. And when it decompensates, what you're going to see is really significant increase in these symptoms on both of these, okay? So just note that. Nursing interventions for both of these types of patients, respiratory status is super important, okay? Always monitor respiratory status, oxygen. In either of these, elevation of head of bed. In right-sided failure, we're likely going to be elevating the lower extremities, okay, to help that offload that edema. Fluid restrictions, sodium restrictions are very important. Monitoring daily weights are very important on these patients. We'll talk about specific meds later and what they are, but obviously the medication regimens on these types of people are super important, right? We talked about the labs and diagnostics a bit earlier, but these are some that you might see on these people, right? Especially a BNP for those that they're trying to differentiate. Is it right-sided or is it left-sided heart failure, or is it a respiratory problem, right? Are they fluid overloaded, or is there some other cause, okay? Things we might give for this, okay? So diuretics, super important. That diuretic helps pull fluid off the lungs, right? So we'll talk about diuretics when we get to our objective about pharmacology. ACE inhibitors, Also super important. Any kind of cardiovascular or cardiac med that decreases the workload of the heart are going to be very important for either of these conditions, okay? And then collaborative management. We usually have these patients looking at by a cardiologist. They may need a dietary consult to limit that fluid and sodium, and then other management places, okay? So this is one of the bigger disease processes I want to make sure that you grasp and understand. Let's move on through a couple of these other ones. So valvular heart disease, it's basically, so we have valves through each of those places of the body, right? As we roll through, we have, I believe, the mitral valve, the aortic, there's another valve. I can't remember what it's called right now. I have to go back to my anatomy up at the top. But what can happen is we have these valves, right? And so as blood flows through the atria to the ventricle and the ventricle to the lungs and from the lungs back into the heart, they pass through those valves, okay? So as they're passing through those valves, what can happen is those valves become very hard, or the valves can collapse, right? And so if those valves become hard and they don't shut all the way, while blood's trying to flow from, say, the right atria to the right ventricle, if it doesn't shut all the way, then we're looking at backflow, right? We're looking at blood not being able to fully flow from one place to the other, okay? So that could be a real issue. It's really important to kind of just to understand that from an anatomy perspective. If the place that is what we're wanting is from one place to another, we're opening a valve and we're completely closing it so that blood can't flow backwards, right? But if something happens and that valve is compromised, a lot of times what you'll see is like backflow, or something is happening that's causing a difficulty for that blood to flow from one place to the other, okay? So lots of times there's different causes for this, and I'll let you guys read through each of these. I'm not going to talk about every single one of them, but our goal for these types of patients is to make sure that if they have, usually what's going to happen is they're going to need a valve replacement at some point, most of the time, or they're managing it with medication, okay? But usually they need a valve replacement. If that happens, lots of times what they're going to need is our anticoagulants. This is super important in valvular heart disease. If a patient ever has a valve replacement, they're always going to be on anticoagulants, like probably for the rest of their life, because we never want to run the risk of a blood clot in an artificial heart valve, right? As if we've taken the original heart valve out, we replace it with something foreign. We never want to run the risk of blood pooling in that place, because if it pools and causes a clot and it travels, it can cause either a stroke or it can cause a pulmonary emboli. Or a heart attack, right? We never want blood pooling in any part of the heart, okay? So it's very important for these types of patients to take anticoagulants. The rest of these, I want you guys to look at the breakdown of each of these. They're not quite as in-depth as those previous ones we talked about. So we're not going to touch on them just a lot, but basically there's several endocarditis, which is an infection of the endocardium of the heart, or of the heart valves, or the endocardium, I'm sorry. There's pericarditis, so the heart is surrounded by a sac, all right, so in pericarditis, that sac becomes infected. So lots of times viral, bacterial infections will cause this. Rheumatic carditis. So strep throat, if you guys don't know, strep throat, if it is left untreated, can lead to rheumatic fever, which actually can cause rheumatic carditis, which is inflammation of the heart due to rheumatic fever. So always make sure you're treating strep throat. It's very, very important for this reason right here. Lots of people in the old days died from this. And then we have cardiomyopathy, which I mentioned earlier, but cardiomyopathy is a disease of the heart muscle itself. There's different types, so there's dilated, hypertrophic, and restrictive. What I really want you to know is that basically if the heart muscle itself is diseased, what they're likely to do is try and manage that. What's going to end up happening is you're going to experience heart failure, okay? So what they're trying to do is manage the heart failure symptoms. There's not necessarily like a be-all, end-all cure for this type of disease. If long-term, if possible, you may be looking at valve replacements or stents or, bypasses, but then also, long-term, if it's not curable, then you're looking at probably like a heart transplant, which is rare. In rare cases, you would probably have to qualify. We are going to talk a bit about this one. So arteriosclerosis or atherosclerosis, super important. Thickening and hardening of those arteries due to plaque. Okay, so we talked about those patients, especially in Oklahoma, right? We have these people, they love to eat chicken fried steak, hamburgers. We like our beef here in Oklahoma. So all of those things are very high in saturated fats. They carry a high fat load, right? As we eat more and more, our cholesterol increases, our lipids increases, our triglycerides increase. So that means that we have basically plaque and fat floating around in our bloodstream. Okay, so as that fat floats around in our bloodstream, what happens is it attaches to the inside vessel wall inside those vessels, and it builds up plaque. So as it just flows and flows, it basically is just, if you think about it kind of like, I'm trying to think of a good analogy, but basically like, if you're running something really thick, right, through a water hose, it's going to continue to kind of like adhere to the edges, right? Over time, it just continues to build up and build up and build up, okay? So if we're looking at arteriosclerosis and atherosclerosis, our bigger risk factors here are basically the dislodging of that plaque or the complete narrowing of a vessel because that artery or that is so full of plaque that blood cannot flow through it anymore, right? So it's a huge problem when that happens, okay? So depending on where that occurs, which it often occurs in the heart, this is when you see those patients end up with what we call a heart attack or a myocardial infarct, because that plaque has become so thick into a vessel that surrounds the heart that blood can no longer flow to a portion of the heart itself. And so you may see patients come in with symptoms of a heart attack. If blood can't flow through that plaque and perfuse the heart muscle itself, we're looking at a heart attack, okay? It can occur in other parts of the body too, but often what we see is it when it occurs in the heart, right? So risk factors: high cholesterol, hypertension, smoking, diabetes, all those things we preach about, like managing our lifestyle, right? Super important for these patients to get their cholesterol levels drawn, lipid profiles. These people are likely, like if they're experiencing cardiac conditions, they're probably going to need what we talked about in that cardiac cath, right? They're going to need to go in and see if they have some blockages, okay? Meds we're going to give these people are usually like cholesterol lowering agents, okay, or antiplatelet agents, but typically cholesterol lowering agents, right? So let's talk a little bit about this. So this is kind of what I'm trying to get you guys to visualize. Normal artery, no fat buildup, nice healthy blood flow. Right here we have a little bit of plaque, right? So you see it start to adhere to that vessel wall, that yellow. And then over here, right, it has built up so much over time that it's completely blocked that vessel, okay? So our heart has its own set of arteries and vasculature that perfuse the heart itself. So if this occurs in the heart, what we're looking at is anything past the point of that blockage isn't getting blood flow to it, right? So we're seeing these patients, their heart muscle isn't getting perfused, and so that's when usually you see those patients start to develop those symptoms of like a heart attack or cardiac conditions, right? Okay, let's talk about hypertension. Hypertension, we know, is high blood pressure. So there's primary essential hypertension, and then there's secondary, which is due to something else, okay? So primary means that you have hypertension probably from like something to do with like your lifestyle, like smoking, or not diabetes, that would be secondary. But say smoking, right? Smoking has caused you to have really hardened arteries that led you to have hypertension, okay? So, and some people are just at risk for hypertension in general. That's just their genetic makeup, okay? So primary essential hypertension, and then there's secondary. So like if you've got kidney disease that's causing you to have difficulty with blood pressure regulation, that might cause secondary. Diabetes might cause you to have hypertension. That would be secondary, okay? There's other factors that can cause hypertension, but if it's just diagnosed as hypertension, like you go in, there's nothing else wrong with you, and they're like, hey, you've got high blood pressure. That's primary hypertension, all right? Our goal is always to monitor blood pressure, educate our patients, make sure they're adhering to their medication, okay? Super important. So we know if we're talking about blood pressure meds, right, we're talking about these antihypertensives, ACE inhibitors, ARBs, beta blockers, calcium channel blockers, even diuretics to help offload the fluid volume status of these patients, right? So super important. Okay. And we all know here, lifestyle modifications are super important, okay? All right. Let's talk a little bit about these two. So peripheral artery disease and peripheral artery occlusion. Okay, we talked about that atherosclerosis up here, right? Building up plaque. If this occurs right here, where you have a complete blockage of an artery, we're not talking about just in the heart, but we're talking like your artery in your leg, or your, typically it's in the legs, okay? So we'll say we have a artery that travels to our leg, right, and it becomes completely blocked. What we're going to see is what we call peripheral artery disease or peripheral arterial occlusion. Okay, so that artery has become completely stenosed and blocked. Blood flow cannot get through. Okay, what we're likely to see on our assessment is we don't have a peripheral pulse, right? If we don't have blood flow through an artery, we're likely not going to have a peripheral pulse, which is super important, okay? We're also going to have signs of ischemia. If we don't have blood flowing through a point of an artery, then our tissue is not getting perfused past that. Very, very important, okay? Some of the other things you might see on these, what we call Doppler ultrasound, they'll actually go in with a Doppler, and I'll bring one into class one day and show you guys, but it's basically a little ultrasound you stick onto a like your radial pulse or your pedal pulse, and it'll tell you if you can hear a pulse in that person, okay, if you can't feel it. And then angiography is kind of like a cath for the heart, but it's for the peripheral vasculature. So they might go in with like a scope or a stent or a camera, and they're going to like try and look and see where the occlusion is and if they can like bust through that occlusion. These patients are going to need vasodilators. They're going to need antiplatelet agents. Usually they have to have some kind of vascular surgery. It's very, very important, okay? So if we're talking about peripheral artery disease is basically like they're experiencing symptoms because it hasn't completely occluded yet, okay? So it's narrowing. We're probably in this stage. We're not getting good blood flow, but it's not completely occluded. These people are likely to they're experiencing no perfusion past the point of the narrowing, right? So they're not getting good perfusion to their skin. They're not getting good perfusion to anything past that point. So you're likely to see a lot of like what we call arterial ulcers, okay? So those types of patients usually experience these because, again, they're not getting perfusion past the point of that arterial insufficiency. If it progresses to the point of it being a complete occlusion, okay, so we maybe something happened, we dislodged a clot or a piece of that plaque, completely closed off our artery, we're no longer getting blood flow past that point at all. If we don't get blood flow past that, everything below that point of that blood flow dies off, okay? So if we can't get any flow, this is going to become necrotic, right? This is not getting any blood flow to it. If that happens, a lot of times what they'll have to do is call it a fasciotomy, where they're actually opening up this muscle right here and they're releasing this pressure. What can happen here is we're developing what we call compartment syndrome, and the pressure inside of this space is so high that it's actually causing tissue necrosis. It's causing that muscle tissue to die off. So if we end up with a peripheral arterial occlusion, a lot of times what you'll have to see is like if they can't bust through it with angiography or with a stent or something, you're likely to see this occur, okay? It doesn't happen very often, but it definitely can happen. Okay, so let's talk about aneurysms and dissections. Okay, so I'm going to go to this picture, and I actually think I put a YouTube video for you guys to watch down here. It's a really interesting video. I really like it. I recommend that you watch it. So aneurysms and dissections. So what happens is we have this, if you look at the anatomy here, right, we have our aorta that comes out of the top of our heart, okay, and it actually, blood flows, right, through that aorta and travels out to the body, okay? What can happen, and these are just typical sites that aneurysms occur, is there's like a weakening in the wall of that artery, in that vessel wall, okay? So what happens is as it weakens, it kind of balloons out. Maybe it doesn't burst, but it balloons out, okay? Let me see if I can yeah, there we go. Okay, so what's happening is like we're ballooning out here. We're weakened, we're ballooning out. So this portion of this vessel is super weak if you consider the integrity of like a normal vessel. Basically, this is like you are blowing up a balloon, and so it doesn't take much for that little balloon to just pop, right? So in an aneurysm, so this is the aneurysm itself. The ballooning out is the aneurysm. When the aneurysm actually tears or blows open, that's when what we call a dissection. So if you think about this being the arterial system of our body, the blood is, and especially if it's right here, these are the most deadly, right? These two. Blood's flowing through our heart, and as that blood's coming through the heart and coming out of the heart, if this dissects or tears, blood is spilling into the basically outside of the vasculature into the body, right? We have no longer have any circulation inside of our vasculature. So you see these types of patients, if these tear or rupture, they're very much like, usually they die very quickly because we can't sustain this, right? In the event that they manage to catch it, they need emergent life-saving surgery. I think I've seen a couple of these, and I don't think I've seen anybody survive one yet. Very, very important to note that these types of people usually don't live very long if it dissects, right? What's important to note is, like, if we can diagnose the aneurysm ahead of time, then usually they can prophylactically perform surgery, or at least monitor it, so that it doesn't dissect, okay? So very important. They usually need a vascular surgery referral. It's very important to control blood pressure in these people, because if you can imagine, the higher the blood pressure on that aneurysm, the higher the risk of it is busting, okay? So that's a super important piece of that. Let's talk about this. So we talked about arterial insufficiency. Now we're going to talk about basically the venous part of this. So what we actually have what we call a venous thromboembolism. So a venous thromboembolism is a blood clot that is in a vein. Okay, so sometimes, like, patients who've traveled for a long time or sat for a long time, or maybe like people who lay in hospital beds for a long time, are at risk for venous thromboembolism, right? The less mobile someone is, the less circulation that's happening, the higher risk they are for this occurring, okay? So a blood clot basically a blood clot develops in the vein. Risk factors for this: immobility, surgery, oral contraceptives increase your risk. The goal for this is to prevent it, right? So if we have a patient who's a surgery, the reason they're getting them up like same day or early the next day is because they're trying to prevent this from occurring. It's also been proven, so our best practice now is early ambulation, compression stockings, and one of the things you're always going to see in the hospital is those SCDs, right? Those pumps they put on their legs, they blow up, they massage the legs. That's because they're trying to prevent patients from getting a venous thromboembolism, okay? Labs and diagnostics that are always going to be associated with this are what we call a D-dimer. A D-dimer is going to tell us if it's elevated, that there's usually a risk for a clot somewhere, okay? And then a venous ultrasound is also going to tell us, like, basically if they're concerned about it, right? They're going to go ultrasound that area, and they're going to look for the blood flow through it and see if they can see a clot. Patients, if we're looking at assessing these people, usually they've got like really hot, red, swollen lower extremities, right? Usually they occur in the legs. They can occur other places, but typically in the legs, right? So these people, again, really hot, red, swollen lower extremities. Now, the difference between the arterial occlusion and this is you're still going to feel an arterial pulse with these, right? It's not going to be reduced because it's not an artery problem. It's a vein problem, okay? So keep the difference in mind. Okay. These people are going to need anticoagulants or blood thinners to help reduce that clot, right? So they may need like heparin or Lovenox or something to help that clot disappear, okay? So what I do want you guys to take away from this is really important. Virchow's triad. Virchow's triad is a classic sign or a classic etiology for venous thromboembolism. So people who have blood flow stasis, right? So those people who, like, maybe their blood's not flowing like it should, or they've got what they call endothelial injury, something's happened to the vasculature, or they have hypercoagulability, right? Those are the three things that typically, like, result in a venous thromboembolism, okay? So, for example, like blood flow stasis, they've had surgery, they're not up and moving, they've had some kind of endothelial injury to the side or to the area, right? Like maybe they broke their hip, okay? So that would cause endothelial injury. And then there's hypercoagulability, right? So maybe like they are their blood, like they have atherosclerosis already, and their blood's very coagulable, or it has the risk of running a clot already, right? So this would cause a higher risk of a venous thromboembolus. Okay, so just keep that in mind. This is a very important classic sign and symptom of VTE. Venous insufficiency. So we talked about arterial insufficiency, where we're not getting blood flow through the artery, but venous is where we're not getting blood flow through the vein. Okay, so we're not getting any venous return from the legs. So what's happening is, so those people who are like standing a long time, even nurses, like you're working 12-hour shifts, you're up on your feet, pregnancy, what we're trying to do is elevate those legs, put compression stockings on. Lots of times what we're doing is ultrasounding to see if that venous blood flow is like impaired, right? But what you're likely to see on these types of people are like, what's happening is like they're developing these like venous ulcers and these really significant varicose veins or these spider veins. So like we're not getting the venous flow back up into the body like we should. Basically it's pooling in these vessels, right? And we're causing this outpouching. So if you'll note, like there's a little bit of a difference between a venous ulcer and an arterial ulcer, but we do need to kind of understand the difference in their pathophys, okay? Okay, so let's talk about objective 5, which is our meds. So some of the primary meds we're going to use in all of these patients, okay? So one of the things we're going to see are nitrates. These are your nitroglycerins, things like that. I'm going to go through these and mention what I think is most important, but I expect you to study your pharmacology just like you would any pharmacology. It's mostly memorization. You need to know what it's for, what its mechanism is, what side effects can occur, and what nursing interventions are we going to do for these patients, right? For nitroglycerin particularly, you're likely to see these people having like chest pain. These people come in with chest pain. We're giving them nitroglycerin to try. So nitrates are a huge vasodilator, okay? They dilate blood vessels really rapidly and they increase blood flow to the heart, okay? But what can also happen is we've dilated the rest of the blood vessels in the body, and so our blood pressure drops, right? We don't have that contraction of the vessel anymore, and so our blood pressure bottoms out. I see this all the time. I gave this poor little old woman a little bitty dose of nitro, and her blood pressure went from like 120/80 to like 70/40 in like 5 minutes. So super important. Nitrates it's blood pressure monitoring is a very high priority for nitrates, but it can help reduce chest pain. We can give this sublingual, transdermal, but it's really important to understand that that's a priority action in nitrates. ACE inhibitors, so we'll note these are our prils, right? Benzapril, lisinopril. These are used for heart failure, also used for hypertension. So if we're looking at the mechanism of this, we're inhibiting the conversion of angiotensin 1 to angiotensin 2. So they're primarily working in the kidneys, okay? One of the side effects you're going to see from these is a dry cough, okay? Super important to note that. People come in and they're like, oh my gosh, I started taking this medicine and I can't quit coughing. It's really common with an ACE inhibitor, okay? Major adverse reactions for this is angioedema. If you note a person who recently started taking an ACE inhibitor and they're experiencing angioedema, which would be facial swelling, they need to stop immediately, and they probably need like some like life-saving treatment, like an EpiPen or something like that, okay? Basically, they need to be treated like an allergic reaction. Other things we're going to do, we always, again, it's a blood pressure medication. We want to monitor blood pressure. We also want to monitor, if we're giving it for heart failure, is it reducing the signs and symptoms of their heart failure, okay? Diuretics, super effective and very common for heart failure. Furosemide, Lasix. I did break diuretics down into several different parts. So we're going to give loop diuretics. So your loop diuretics or your furosemide, Lasix. We're trying to reduce edema. We're trying to reduce the fluid on the lungs in those heart failure patients, okay? We're going to inhibit sodium reabsorption. So sometimes what happens is we're washing everything else out too, right? We're grabbing everything and it's just rolling out with our urine. So hypokalemia can happen. If we're taking too much, we can cause hypotension, dehydration. Very important to monitor electrolytes and that patient's fluid balance. It's also important to make sure we're not giving them too much, right? We want to make sure their blood pressure maintains, okay? Thiazides, so same, all of these are going to kind of have the same not mechanism, but the same idea behind them. We're trying to reduce fluid, we're trying to reduce edema, we're trying to reduce hypertension, okay? But the mechanism of each of these types of diuretics is a little bit different. So if we're looking at loop diuretics, this is its mechanism. If we're looking at thiazides. This is its mechanism. All of them have the potential, though, to wash stuff out, except for the potassium-sparing ones, right? So with potassium-sparing diuretics specifically, we want to make sure we're actually monitoring for hyperkalemia, not hypo, right? So it doesn't grab onto potassium and wash it out, but we want to make sure that patient's not taking or eating anything that would increase their potassium level, okay? Super important there, okay? That's kind of diuretics in a nutshell. Let's talk a little bit about beta blockers. So our propranolols, metoprolols, so as we know, those all end in OLOL. These are used for our hypertensive patients, patients who have heart arrhythmias, angina, which would be basically chest pain, okay? These are typical drugs we're going to see. Beta blockers reduce our heart rate and reduce the contractility, okay? So it keeps our heart from beating as fast. So the goal behind that in a patient with heart failure, right? Our body's trying to compensate by beating faster, okay? So think about trying to, we're trying to reverse that, right? We're trying to, and hypertension too, right? We're trying to overcome, our heart's trying to overcome the pressure on that vessel so it beats harder and it beats faster. If we're trying to reduce that, what we're doing is we're slowing the heart rate down, we're allowing the ventricle to fill all the way up, and then we're actually reducing how hard it has to contract to do that, okay? So that's the mechanism behind a beta blocker. Sometimes, if we're given too much, we can actually cause bradycardia, so we can see that heart rate slow just a little too much. Hypotension. Any of these have the potential to cause hypotension, right? If we're given something for blood pressure, we need to know that we're not giving too much, okay? Other things we might see, super important to note, like, if this occurs. So we don't want severe bradycardia, so we're looking at, like, heart rates of 30s, 40s. That would be really bad, and then a heart block, okay? We always want to, again, monitor the heart rate and blood pressure. Very important piece. Calcium channel blockers. So their mechanism, they block the calcium channels in the heart and actually cause vasodilation and reduce the contractility of the heart. So it allows more blood to flow through the vessels around the heart, okay? Same issue can occur with calcium channel blockers as can occur with beta blockers. So you can result in hypotension, bradycardia. If we actually, this can actually cause heart failure if we give this in certain types of patients. So we want to, typically that's a physician-related decision, but we'd also want to monitor for signs and symptoms of heart failure on a patient that started a calcium channel blocker. It would be really important to note that. Always, again, heart rate, blood pressure, super important, okay? There's some other, this is the last blood pressure med we're actually going to talk about, but an alpha-2 agonist like clonidine. Every now and then you'll see clonidine given for hypertension if other ones aren't working. Some things clonidine, they don't typically prescribe it as often because it causes a few more side effects. So drowsiness, dry mouth. We would, again, same concept. We always want to monitor these patients for their blood pressure. Clonidine is an alpha-2 agonist, though, and actually only, so we'll talk about that in a different lecture. Never mind. We're not even going to get into that. Okay. So anticoagulants, we talked about those people with arterial occlusions, arterial insufficiency, venous insufficiency. We talked about venous emboli, thromboemboli. If we're treating those things, we have to give them an anticoagulant, okay? Heparin, warfarin, Lovenox. So what we're trying to do is prevent and treat blood clots, okay? What they do is they interfere with the coagulation cascade of the blood. They actually prevent that blood from coagulating. Side effects from these, if we give too much, and there's a reason we have to monitor the levels of these drugs in patients, is because they can bleed, okay? It can actually, we can give too much, or it can be overly therapeutic, and we cause them to basically bleed out, or their blood count goes down too significantly. There's another thing called heparin-induced thrombocytopenia, where their entire blood count goes down. Their red blood cells, their white blood cells, their platelets. Really important to monitor for any bleeding in these types of patients, okay? So for heparin patients, we're monitoring an HPTT, For your warfarin patients, you're doing a PTINR. We're always monitoring for how therapeutic it is, how therapeutic our coagulation is when we're giving drugs like this. On that note, if we go to thrombolytics, right, if we have a VTE, we have an arterial occlusion, we have a myocardial infarct, so we have a artery in the heart, around the heart muscle that's blocked, which you might see given as a thrombolytic. They're trying to dissolve that clot, okay? And these work faster than your anticoagulants, okay? So thrombolytics work much, much faster. What we're doing is we're completely dissolving that blood clot, okay? The biggest concern with these is they can actually cause you to bleed because they're literally dissolving any kind of anything inside the blood, okay? Other things that can occur with this, intracranial hemorrhage. So if you're bleeding here, right, we're trying to dissolve a clot here or here, we can also bleed in the brain. So we want to monitor for any kind of signs and symptoms of that, right? Biggest thing in these is to monitor for bleeding. Always, assess for vital signs. Make sure that your patient isn't exhibiting signs and symptoms of bleeding. Of these, alteplase is the one you're going to see, and you're probably going to hear it referred to as TPA, okay? Antiplatelets, so those patients who have had an MI, or maybe they had a stent placed for a vessel that was narrowed. These people are going to be on things like Plavix, aspirin, something to prevent blood clots from forming, right? In the future, okay? Another common one is Eliquis, right? So my father-in-law had a quadruple bypass about a year ago, and he will take Eliquis forever, right? Because those new vessels, we never ever want to run the risk of those new vessels developing a blood clot, okay? Especially if they have atherosclerosis or have a history of atherosclerosis. It's very important. Same concept here. The biggest risk that occurs with these is bleeding. We're always trying to monitor these patients for risk of bleeding, and that includes internal and external bleeding. So if they ever come in and they're like, man, I take Eliquis, but like I'm really dizzy, we need to make sure that they're not bleeding internally somewhere, right? We need to make sure that they don't exhibit signs and symptoms of that. This one's not quite as common, Nasiratide, but basically it does help us in basically a patient who's had heart failure that's completely decompensated. It causes vasodilation and natriuresis. So it has to do with the B natriuretic peptide. Again, it's not as common as a med. I'm not as familiar with it. But basically, this is the breakdown of that med. One of the biggest things that can occur is hypotension. So we always want to make sure we monitor blood pressure. Digoxin. So digoxin you will see. It's very common. Pretty familiar with it. One of the things, it is a primary drug used in heart failure, okay? So if we have a patient with heart failure, one of the things we're trying to do is reduce the workload on the heart. What it actually does, and usually it's in combination with something else that's relaxing the vessels, but what it actually does is it increases the force of the contraction. So what you might see is like maybe they're taking a beta blocker to slow the rate down, but they might be taking digoxin in order to help that cardiac contraction so that they get the maximum amount of blood pushed out of the heart with one pump, okay? So we talked about if your heart's failing, what your heart's going to try to do is just pump faster, right? We don't want it to pump faster. We want it to pump better, okay? It's quality over quantity, okay? What we want to see is that heart has a normal healthy rate, and when it contracts, it's getting the maximum amount of blood flow out of it as it can, right? The thing about digoxin is it can have a lot of side effects, okay? Nausea, vomiting, bradycardia if we're giving too much. If we're giving Dig IV, one of the primary things I want you guys to know is it has to be pushed super slow. You can never push digoxin really fast because it can brady them down and it can cause an arrest if it's really concerning. Make sure if you're giving digoxin to someone, you're giving it over whatever your order says, over 2 minutes, over 5 minutes. Make sure that's a very important piece from an aspect of digoxin, okay? Other things, if we give too much over time, if they're taking it for an extended period, it can cause dig toxicity. So these people usually have to have frequent labs monitored. in order to make sure that their dig levels aren't too high. Okay, very very important. Amiodarone is an antiarrhythmic or antidysrhythmic. It treats arrhythmias. It can affect sodium, potassium, and calcium channels. Can cause hypotension if we're not careful. Bradycardia, heart blocks. I use amiodarone very frequently for AFib, but they do use it in heart failure some. So if we're talking about meds, nursing considerations. Always educate your patient on the med they're taking, especially cardiac meds. They can have some very significant side effects. It's very important that they adhere to the treatment regimen. Super, super important, okay? Medication reconciliations are very important. Again, if they're getting meds from one place and they have a cardiologist who gave them new meds, cardiac meds interact with a lot of things. We have to make sure that they're not taking something that can interact with that cardiac med, okay? Other things, vitals, electrolytes, lab values, all very, very important. Biggest teaching piece here, make sure your patients are taking the medication as prescribed, okay? Teaching them that is a super important piece of nursing. Let's talk about objective 6. So, nutritional needs of these patients, right? So, if we've got a patient who's experiencing a heart condition, our goal is to put them on a heart healthy diet, right? What we're trying to do is put emphasis on those healthy pieces: fruits, vegetables, whole grains, lean proteins, healthy fats, reducing that sodium, reducing those saturated fats. So if we move to our next slide, we're trying to limit sodium, right? We're trying to limit anything that exacerbates heart failure. Water follows salt, right? So if we're increasing our sodium intake for a patient who has heart failure, who's retaining fluid, or they're retaining fluid in their lung spaces, right? Sodium's just gonna continue to exacerbate that, right? Our body's gonna hold on to more fluid because it's trying to dilute that sodium and dilute that salt. So we want to make sure we're limiting our sodium intake. It's super important in heart failure patients, and in hypertension. But again, the overall goal here is a balanced, healthy diet with limitations of especially these things. Okay. Specifically, we want to make sure that we're giving them enough omega-3s, fiber, potassium is super important, and magnesium is super important, okay? The book actually talks about the DASH diet, which is if you ever have or hear a dietitian talk to patients about heart healthy diets, this is a lot of what they teach. So dietary approaches to stopping hypertension, okay? A specific eating plan, it helps them lower blood pressure, it focuses on those healthy pieces and the limitation of those pieces we already talked about. Other things that are important: fluid management. Again, if they're in heart failure, they may need to restrict fluid. Weight management is also very important. Weight loss is, if they are overweight, that is an important piece of it that they should consider. Alcohol consumption is another a factor we should address, and then caffeine as well, okay? Specific considerations. So heart failure, sodium and fluid, very important. Hypertension, sodium in the DASH diet. Atherosclerosis, limiting fats and cholesterols. Okay, we talked about that one earlier. And then if they've got valvular heart disease, depending on the meds they're taking in, all of these conditions we talked about, they're taking meds that require them not to eat certain things. That is a teaching point we would want to make, okay? Other considerations, so heart healthy diet. If we're talking about nursing interventions, our assessment, we need to have a thorough dietary intake and a thorough history, okay? Education, provide education on their eating habits, their food choices, counseling, monitoring, and then collaborating with other professionals, especially dietitians, right? Okay, let's talk about 7. Compare and contrast the cardiac differences across the lifespan. We have another lecture. We have congenital heart defects where we're actually going to talk about pediatric cardiac conditions. But we are going to talk a little bit about the differences here because this lecture primarily it mostly focuses on adults. However, a lot of these conditions can also occur in children. So please keep that in mind, okay? But in infancy and childhood, if we're talking about cardiac differences throughout the lifespan, right? Heart rate is higher in kids, right? Cardiac output is dependent on their heart rate. Okay, they have a smaller tank, so they have a smaller stroke volume. Okay, they pump out less at a time, so their heart rate is higher. Our blood pressure is lower in infants and increases with age. Our structure does change, and we'll talk about that when we talk about that congenital heart defect lecture. But our heart grows, right? So as we grow, our organs grow. And then congenital heart defects. That we have a whole lecture dedicated to that, so we won't touch on that right now. As we age again in adolescence, we continue to grow. Our heart rate continues to decrease. Our blood pressure continues to rise gradually. And then as we enter adulthood, we reach the peak of our functional capacity, right? Our blood pressure may start to rise gradually, especially if we're participating in lifestyle factors that don't help us manage that blood pressure. And then our cardiovascular health, right? So we reach adulthood, it's when we really need to start considering cardiovascular health, right? And those cardiovascular diseases we just talked about. Older adults, okay. Our structures, this is the biggest piece of this objective. Structure, so if you think about somebody who's been alive for 80 years and their heart has pumped for 80 years, the muscles pumped for 80 years. We know if we work a muscle, it has the ability to enlarge, right? So older people, typically their muscle may thicken, the valves become stiffer. So, I mean, just as you age and that organ wears and tears, like these things can occur, right? Our electrical system can lose cells, which can result in a naturally slower rate. Our vessels and arteries become stiffer and less elastic, so that's why it's more common to see older people with high blood pressure. Our cardiac output can potentially decrease. Okay, so let's talk a little bit about this. Baroreceptor sensitivity. Our baroreceptors actually live in our carotid arteries. And so they are important to help us regulate blood pressure when we change position, especially. So as those baroreceptors are stimulated, it tells our body to how to help regulate our blood pressure. Which is why, and I'm just going to throw this in as a side note, if we put somebody in Trendelenburg and throw all of the blood back up toward their carotids, it basically will increase their blood pressure, right? It's stimulating these baroreceptors is what it's doing. So as people age and those baroreceptors become less sensitive, we run the risk of having more things like orthostatic hypotension because our body isn't able to respond to that mechanism as quickly. Okay, so you see those people raise up, they're dizzy. This is part of the reason why. Older adults are also at higher risk for cardiovascular diseases for a lot of different reasons. Lifestyle, genetics, again, just generalized wear and tear, right? So I did throw this little chart in here. It kind of shows you the breakdown between the things, but basically like as they age, what changes in reference to this feature, okay? And then as a whole, nursing considerations, make sure we're doing an age-appropriate assessment, right? Understand what normal variations are in the heart rate, blood pressure, heart sounds. Early detection of issues is super important, especially if we're talking from a pediatric, which we'll talk about that in a different lecture. Health promotion is very important across the lifespan. Heart-healthy diets are very important regardless of whether we have cardiovascular disease or not. Med management is very important. And then education. Patient education, as always, very, very important for patients, especially from a cardiovascular standpoint. So that concludes everything that I have to say. I know that was like fast and furious. I'm going to post this. I will send you guys out some more information. Please feel free to message me or let me know if you have questions.